So without further ado, I would like to start with our first speaker, Professor David Askenazi. He's a professor in pediatric nephrology from University of Alabama in Birmingham.
Good morning, everyone. Thank you very much for being here. And Robbie, thank you for the opportunity to speak here. And thank you. It is my pleasure to be here at the 29th CRRT conference. So I'm going to talk to you about standardization and personalization of renal replacement therapy in the ICU. Here's my potential COI, and there's nothing pertinent to this talk. I want to talk a little bit about understanding why standardization is critical and needs to serve as the fundamental base for what we do to optimize care. I also want to dive into why personalization is also really important as we think about providing care for our patients. And hopefully what we can do at the end is you'll get a sense to and recognize how both of these are not only interrelated, but are interdependent. And perhaps you can have a different framework of how you provide care for your patients and how you provide care for your program. And we'll discuss why as we move forward with newer filters, newer technology, as we try to add layers of what we do to other disease process, personalization and standardization are going to be even more critical in the next phase. So which one is better? Let's step back a little bit. Do we personalize in our pediatric ICU? I think the answer is of course, right? We take care of patients with all sorts of different types of conditions. We give them all sorts of different types of interventions. And we have very different size patients, for example. This is a patient that we took care of who was, about 2 kilos on CRRT. And certainly there's some patients in the wonderful state of Alabama who weigh more than 200 kilos. But we also standardize what we do with them. For example, we standardize dose of chemotherapy based on body surface area or weight. And I think in the ICU, in the adult world, my suspicion is that you probably also personalize, whether you're taking care of a fragile grandma or a big guy like The Rock. I think you're going to be doing personalization and standardization at the same time. So the framework that I want to use today is to ask the following questions. Well, what are the goals of what we try to do? And in those goals, do we personalize or standardize or both? And the goals that I think you'll agree with me are, one is to correct and maintain homeostasis of uremic toxins, maintain homeostasis of electrolytes, acid base, maintain and correct issues with fluid. We also, in our population, take care of patients with hyperammonemia, but you may find patients that you're caring for that have other endogenous or exogenous toxins. And there's been a lot of conversations about how our platform can potentially do things like immunomodulate, source control, and removal of inflammatory mediators. So if we look at all these goals, we can ask that question. But it's also important to recognize that we have other goals when we do CRRT. We have our goals to not hurt our patients. We have our goals to not, cause hemodynamic instability. And we speak a lot about the possibility of how what we do removes things like medications and nutrition. And we don't want to be causing problems there because that takes the patient away from what our ultimate goal is for them to have success. And the other thing we need to do that I think standardization, personalization can really kind of cause some frantic and panic and freak people out. So one of our goals is to have a system that not only maintains our circuit running well, but that allows our program to have clear communication in what's a very dynamic environment that involves multiple people at different places, and in some places, at multiple different ICUs. So do we need to personalize or standardize how we dose our therapy? Well, let's take a look at it. We have talked at this meeting and now for about a decade how the ATN trial and the Renal trial did not find a different dose. And so we have learned that more is not better, and so perhaps we should standardize the dose of clearance. That's great. It's important to remember that CRT dosing, whether you're at 20 per kilo or 15 per kilo, you're going to have much, much higher clearances from a daily perspective and from a weekly perspective than an intermittent hemodialysis, even though the intermittent hemodialysis is more efficient. The fact that CRT is 24 hours a day makes it much more effective for the 24-hour clearance. It's also important to recognize that we don't really dialyze people because they're having uremic frost. They're not having very significant complications. And I asked the following question: if you had a patient who had severe nephrotoxic AKI and has stage 3, or creatinine is up to 5, 6, or 7, you're probably not going to dialyze them as long as they have good metabolic control and good fluid control. And so studies like ICU that look at different timing of CRT based on a creatinine level may not really be appropriate for things like clearance. And so are we surprised then that the dose and the toxin removal rate doesn't matter in what we do? And I would say the following, that the dose does not really change our outcomes. And so in that sense, standardization makes a lot of sense. However, when we talk about other things, the other goals that we have, things like don't remove medications inappropriately, the dose of RRT absolutely does matter. And we hardly know how to dose of medication is what I would argue. We think we do, but think about how that happens if everybody's personalizing their dose of CRT. So my light bulb on this issue really turned on when we had a patient who had persistent bacteremia, and they couldn't figure out why he was having, over and over for weeks, these low levels of bacteria in his blood. And as I came, on a Monday morning, I realized that with the citrate and the calcium, this patient was getting, somewhere in the order of 80 to 90 mils per kilo per hour of fluid removal. So he didn't need more scans, or he didn't need a surgeon to go find why he was having an infection. He needed us to really standardize our dosing of the medications coupled with our dosing of our CRT. And I remind you guys of a quote that I remember Bruce Mueller said, people don't die of cephalosporin toxicity, they die of gram-negative sepsis. So if the dose doesn't matter from a uremic perspective, but does matter from a medication perspective, well, then maybe we need to think about how we dose based on not uremic clearance, but making sure that it's not going to mess up our medications. So in our hospital, we have this little chart. It's very, very handy because I can walk in and have this information to know where to start as the beginning of a conversation. But that is based on a standard dose that we use in our hospital, which is about 24 mils per kilo. Nutrition is something that we've talked about. This is a great review that Marlise and her colleagues put together about nutrition and micronutrients, and the challenge that we face with trying to figure out how to dose and the problems that can occur. But in this paper, there's not even mention of how dose potentially of CRT affects it. So if we're already having trouble figuring out how nutrition should be delivered in the RRT, and we're trying to make studies, and we're trying to provide care where everybody's changing the dose willy-nilly, then it's going to cause problems because the dose of RRT absolutely does affect the nutritional clearance. And we don't want to freak people out, and so how can we expect ourselves and our colleagues to help us provide adequate nutrition and medication when everybody's changing dose on the fly, when it's their turn, they decide to switch up how much clearance they're going to give. So standardization is essential to any RRT program, and we can't have everybody doing whatever they want when it comes to dose. Electrolytes and homeostasis is something that you have to think about in your program. There should be some personalization and at the same time standardization so that you can figure out how we're going to titrate, who's going to titrate the phosphorus, for example, and it's just something that we have to consider. In our program, we put additives in 98% of our bags, and the pharmacy's happy to do it. And it makes sense for us because it limits how many different flavors of fluids we have stocking in our rooms. So we've talked a lot about fluid in this meeting. We want it to be just right. And we've learned things like, timing may dictate how much fluid you want a patient to have. This is nice figures from the pediatric ADKey that talk about this curve of fluid balance. And you can see on panel B there that different people are going to have a different pendulum, depending if they have cardiac failure or if they're an ultra marathon runner. They may have different curves, and so we think about patient differences and then the factors that we can do to implement fluid removal is going to vary on the kind of patient that we have. And that makes sense for us to do this in a personalized way of fluid removal. And we also don't want to cause problems. So the kind of problems that we don't want to have is hemodynamic instability. And so my question is can we develop a framework to do that a little bit better? And I think we can. Because we can be precise about the rates of fluid. We can say to ourselves, well, we want to achieve the goal that we're removing fluid in a fast enough way that the patient's getting better, but not so fast that it's causing harm. And there's a couple ways we do it. One is, I've been doing this for a while, and sometimes I walk by the bedside and I say, well, why don't you go with 80, right? We're going to take off 80 mils an hour. And we give it some kind of a gestalt. And we do that only after we've been doing this for a while. But if you sometimes have been around where there's Cavalier fellows that are just starting, they'll throw a number and you go, wait a second, where'd you get that number? And so perhaps we need to slow down and think through how we make a choice and do that out loud in front of the team so that we can standardize how we think about making these decisions about personalized rates of fluid removal. So the way that I think about it when I slow down, and sometimes it's hard, is just ask bunch of questions. What's the current fluid balance at this moment? What is the optimal liberation weight? Not necessarily the optimal dry weight for my patient, but where's the place that this patient's going to have the best likelihood of liberating? Is it the fluid accessible to me, or is it in the tissues? How quickly do I want to take it off? What are the fluid goals over a period of time that I want to do? I want to take off 1 liter an hour, for example, and then certainly we think about how to get there. We also need to develop guardrails to tell us whether we're going too fast or too slow. And certainly, having conversations with the bedside nursing team to say, okay, look, if you start to see this, you please back off or please give me a call. And we also want to make sure that people don't freak out, right? And so we need to have a common language about fluid removal. In our program, we don't say negative 100 or positive 100 because we had a patient who had a really bad event that occurred because the physician said negative 100, but really to the nurse meant leave on 100. We've done things like CRRT where we do high dose clearance. And so here's the example that Stu and his group published. I want to show you kind of how we think about it in our program when it comes to changing dosing of CRRT for hyperammonemia and other endogenous issues. We speak in terms of standard dose, and then we talk about gears. We talk about 2 times the standard, 4 times the standard, 8 times the standard, and it allows us in a quick way to communicate with our ICU, with our nutritionists, with our pharmacists, what we're doing, so that the entire team can kind of have a sense to what we're doing. And if in patients who have liver failure, I found that this is really, really important because we can sometimes, shoot ourselves in the foot by trying to remove ammonia, for example, at a high rate, but we're also clearing their medications. I want to show you an example of a kid we took care of. This is a 4-day-old, 3.3 kilo kid, and he had a very severe hyperammonemia. You could see that by the time we got called to the time we actually came to our hospital, his ammonia had risen to 3,500. And we put him on, 12 times standard dose, which is about 1,000 mils per hour. And you could see by number 2, at around 4 hours after we started, even though we were doing that high of a rate, we were still above 2,000. So I said, well, let's go to 18 times standard clearance. And then eventually we backed it off to 9 and then to 1.5. So this has helped us to standardize the way we talk so that we could personalize our dose in certain situations. And certainly we've talked about how the future of CRRT is not CRRT. This was Stu's quote a couple of years ago. And so the future of CRRT is perhaps continuous non-renal renal replacement therapy. So I like this story. The introduction of penicillin in 1940, right, was this huge medical breakthrough. And I imagine that at one point there was some person that said, well, let's give more dose, right? Because not everybody gets better when you give them a shot of penicillin. But they soon realized, and we now realized, that you can't just double the dose of penicillin and hope that everybody's going to get better. Because ultimately what you want to do is you want to titrate not the medication dose, but you want to change the medication for different scenarios. And so now in the infectious disease world, you have all sorts of medications that you could put into your same syringe that you used initially, but it completely has a different effect. So penicillin is great, but sometimes we need a different medicine. So we know how to use these extracorporeal devices. Adding or substituting these filters is actually pretty easy for us because we have that skill set. And you've heard about a lot of these filters. I'm not going to talk to them in great length, but just to remind us that we now have different types of things we could put into our platforms that potentially are going to allow us to personalize. And we have things like tandem therapies with pheresis and CO2 and Mars. And certainly we've said this in this meeting, but I'll emphasize it again, that to provide timely, safe, and effective therapy, we need explicit clinical and biological criteria, objective indicators of response, and standardized guidelines and process of care. Because maybe personalization and standardization not mutually inclusive. Maybe they actually fit together better, like peanut butter and jelly sandwich. And to be good at this, we have to have a great framework in our hospitals of the policies, procedures, and guidelines that we have that aren't just pieces of paper, but they're conversations that we have with our partners across our entire institution to assure that everybody's on the same page. With that, I will summarize that achieving the goals of CRRT, we need both. Be mindful of medication and nutrition, especially as you adjust your dose. Take your time as you personalize your fluid removal rates. We have some great new membranes available, and we're going to need to be able to standardize our approach so that we can personalize these therapies. And certainly integrating teams are going to be incredibly essential as we move forward. Thank you very much.